I've been watching your videos. I just don't have Friday off, but I do appreciate that you do all these videos and I've watched them.
Oh, that's very nice of you. Thank you so much. Actually, so many people are uncomfortable because I'm going to ask them a question and they think I'm going to ask them a question, so they don't come live. And I teach practices and stuff, and they're like, "Oh, I watch, but I don't want you to talk to me. I'll watch after the fact." So thank you for coming today. As always, I won't pick on you directly, but if you do want to answer questions, do like jump in. Um, Maya is old hat, so she's here as a mentor today. Was it last
Not
year?
really, maybe. Sorry,
Was it last year or the year before?
last year.
Yeah, right. Gosh.
Well done.
Yes,
Thank
yeah.
you. Yeah,
Gosh.
it was a wild ride, so how you
It
guys
really,
feel?
it really is, isn't it? And in
Yeah.
hindsight, do you realize how clever you were right before the exam?
Yes, and how much knowledge I had right before that a lot of it just sort of disappeared. But hopefully it's in there to be remembered if I look at my notes again.
And how did you feel a week before the exam? Were you feeling confident or were you feeling like you didn't know enough?
I definitely felt like I didn't know enough.
Yeah.
Yeah. I think with medicine as well, there's just so many
There's
fields that
no-
no matter how hard you try, and I really studied a lot, like you just never feel 100% confident about every tiny thing. It's not
Yeah.
like you're sitting cardiology memberships and you just know every single thing about the anatomy, embryology, physiology,
Mm.
pharmacology of the heart. Like this is just it's just unrealistic to know every tiny thing. So I feel like a lot of us felt like that.
So I reckon, like,
Yeah.
if you talk to people in every subject, they're like, yeah, but medicine, you don't need to know as much detail as ophthalmology, or you don't need to know this much as this, and blah, blah, blah. So everybody feels like that.
Yeah, yes.
But it's nice to get that perspective from you because Maya's actually doing a residency in ophthalmology now. Correct?
Yes. Yeah,
Yeah.
yeah, I am. Yeah,
Yeah.
very different.
Yeah.
But the internal medicine membership is super helpful.
Yeah. Yeah, for sure. Particularly like often you're dealing with diabetics and unwell
Yeah,
people with ocular disease for sure.
yeah, exactly. Yeah, yeah.
Um,
That was definitely worthwhile, despite the stress at the time.
yeah, for sure. So the subject today is nutritional management of hepatobiliary, gastrointestinal, and pancreatic disease. I don't want to just work through the Edinger chapter just because it's memberships next week, but I also don't want to fry everyone's brains and make them feel overwhelmed. So if like I'm wording questions kind of off the cuff, if you don't know what I mean or what I'm getting at, just say, I don't know what you mean. Like, don't feel like you don't know the answer because it's probably that I've worded the question like without too much forethought. And the other thing I'll say is that I've been mentoring Helen, working with Helen for a long time now. And she's been sending through answers and answering things in tutorials, which Cheryl, you've probably seen. The level that Helen's answering at is way above what you'd expect for membership. So don't, if other people, and that goes across the board, like everyone's got pet subjects that they really understand and really nail. So if you hear someone absolutely nail an answer, it doesn't mean that you're not at pass level. They might be at like high distinction or fellowship level. So like don't be intimidated if somebody knows more than you about something. It might just be their thing. Or they might be Helen who knows everything about everything. And
I
challenge.
don't feel like that.
I know, but it's the week before the exam.
I'm like, maybe I should just do them next year.
Too late.
So many of us said that and then
5 years.
passed anyway.
And no, it's too late. That's how I feel.
I'm gonna kick you out the door of my car outside the exam on Monday. It's Monday, right?
Yeah, Tuesday. Yeah.
Tuesday, yeah. Yeah, you're doing it. It's too late now.
Yeah, it's too late.
Okay, so we might as well start with hepatobiliary disease or like the diseases that we are supposed to be talking about. And I will like I think nutritional management is not, you can't ask that many questions on, but you can use nutritional management to display an understanding of etiology and pathogenesis of disease sometimes. Um, so, for example, if I said, what are the nutritional goals in managing a dog with chronic hepatitis? What would you feel like was important to cover?
I'd probably say making sure that you're paying attention to your protein balance. So if they've got a chronic inflammatory state, they are going to be in a catabolic state. So we want to provide adequate energy and adequate protein, importantly, to prevent muscle wastage, but also monitoring for liver function for the development of hepatic encephalopathy.
Great, excellent. So once hepatic encephalopathy develops, what are you trying to target by reducing protein? What are you trying to reduce in the system?
You're trying to reduce protein available for the production of ammonia, so protein breakdown that's leading to bacteria producing ammonia.
Great. Excellent. So the more protein, the more ammonia, essentially. So that's why we see hepatic encephalopathy after a high protein meal in dogs with shunts. So we want to limit like boluses of protein, but we want to try and provide adequate protein so that we don't get muscle wasting. Particularly, often these are young dogs and they're already pretty stunted growth-wise. What about if I said, what's nutritional supplements might we add to a diet of a dog with hepatic or with chronic hepatitis?
Denamarin.
Excellent. What is denamarin?
It's too long. Silibillin something.
Yep. Good. There's actually
An
two.
antioxidant that targets the free radicals.
Yes. Yeah, exactly. Yeah. So that prevents ongoing damage to the liver, oxidant damage to the liver. There's actually two components of denamarin, and hepatoadvanced. Yeah, it has 3 components in it. So there's not a lot of like really high level evidence for liver supplements for supportive care. The one that has the best evidence, interestingly, is milk thistle, which is in denamarin and hepatoadvanced in silibin.
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 Yeah.
I really said psilocybin. That's different. Yeah, silibin, and then S-adenosylmethionine, SAMe. So if in doubt, if you can't remember that word, write SAM in capitals and then the little e. SAMe and silibin. So silibin has really good high-level evidence for antioxidant effects in the liver. Vitamin E actually probably has the next level of evidence, and that's in hepatoadvanced. And then SAMe in humans has a reasonable level of evidence, but in dogs we've just got absolutely none, and cats I should say, absolutely none, but theoretically should be incredibly beneficial when we've got hepatocyte damage, hepatocellular damage and inflammation. SAMe also acts as a thiol donor, so I don't know if anybody has watched the liver detoxification rounds we did. Thiols are the component that facilitates glutathione detoxification pathways. So if you have a thiol donor, you like amplify that pathway and make it more able to detoxify a toxin that might be causing ongoing damage. And when we say toxin, it's not necessarily an exogenous toxin. It might actually be something absorbed from the gastrointestinal tract. And then those thiols actually suck bile into the gallbladder or into the biliary system, so they're actually choleritic to a certain extent as well. I just feel like it's just flushing the liver toilet, basically. So in theory, good idea to add them, but not necessarily too evidence-based. But I think I would definitely have it in my answer key if I was examining this. What about if the cause of the chronic hepatopathy was copper storage? What else would you add?
So as well as restricting copper in the diet, you can add zinc as a supplement because it upregulates your methionines, which are the compounds in your enterocytes that can trap heavy metals. And then when the enterocytes die every few days, they just slough off with the copper rather than it being absorbed, and that they have a higher affinity for copper than zinc, so you upregulate them and then bind your copper.
Excellent. Fellowship level answer, but I would have taken zinc for 4 marks.
Okay. Zinc.
Excellent. So that's pretty much the whole, like, what I'd expect in my answer key. So the low protein, ideally, once we've got hepatic encephalopathy, but before hepatic encephalopathy develops, definitely make sure we've got adequate protein to support normal muscle mass. And then we want those supplements that we talked about. And then if it's copper specific, then we want to add zinc as a supplement. There's other medications that we might use for copper storage, but that's not what the question asked. From memory, what I asked.
Does that mean that if you're dealing with, if you've got a dog with cirrhosis, liver cirrhosis, or no ongoing hepatic injury, is there any point to those supplements?
Is there any point in the supplements?
Yeah, if you haven't got ongoing hepatocytic injury.
It's a really good question. Define cirrhosis for me.
If you've got end-stage cirrhosis where you only just have, I guess, you've got your dog that comes in, it's got not great liver function, but you know, you run your ALT, you run your bloods, and then there's no sign of increase in your parameters. And I guess, what are you treating? If there's nothing to treat there, if the injury's already happened, and then you've just got cirrhosis in the future, like fibrosis and cystic disease. Do you know what I mean?
Yeah. So the liver is such a weird organ in that when it gets inflamed, it usually stays inflamed. And what we see is this like increase in ALT, and then we lose enough hepatocytes that the functional mass of the liver goes down. And even when you've got active injury of those hepatocytes, your ALT is still coming down because there's less hepatocytes releasing their ALT when they get injured. So quite often with the really bad livers, the ones with the ascites and like full portal hypertension acquired shunts and stuff like that, the ALT is not very high, if high at all. There's just not enough hepatocytes left. But every single one of those hepatocytes is important. So if there is an injury or ongoing inflammation, we'd have to biopsy to detect them. And I don't want to take any liver cells out of this dog. I want to leave them all in there. So I think the risk of biopsy to prove that they need these supplements is much higher than just giving the supplements if the owner can stretch to it financially, if it's not impacting their bond, giving medications and things. So
an animal with significant liver injury, even if it was acute, you would keep on supplements for the rest of their life?
Not necessarily. So if it was quite a short-term injury, that's much less likely to cause fibrosis and ongoing liver damage. So if I got an ALT that was sky high for a week and it came down to normal within a month, I wouldn't leave those guys on chronic supplements. But dogs that have had ALT elevations over years, I would say just leave them on for life if you can stretch to it, because they're not cheap.
Yeah. Okay.
Yeah, so because there's so much immune activity within the liver, because it's like mopping up everything that comes from the gastrointestinal tract. As soon as a hepatocyte ruptures and it shows all its internal antigens, the internal immune system forevermore is like, hepatocyte, like you're inflamed. It just like perpetuates itself. So chronic hepatitis, like sort of usually there's an inciting event that we never know what it was, and then they just get this chronic hepatitis ongoing. Okay, next question. Should we stay on liver or do you want me to jump around?
Don't mind.
Okay, it's easy for me to go in order.
Okay, go in order.
Okay. Tell me about management, or nutritional management of a cat with hepatic lipidosis.
I don't want to keep talking if anyone wants it, but I'll start. Feel free to jump in. So in hepatic lipidosis, you've overwhelmed your liver's ability to process free fatty acids, which have been liberated from adipose tissue. So the most important thing is to address the cat's protein deficit. they are obviously obligate carnivores, as we know, and they have a lot of essential amino acids. So carnitine is needed to transport your free fatty acids into mitochondria to be used in the Krebs cycle. So as soon as they're a little bit protein deficient, that will stop. Arginine's needed for the urea cycle, so to process your ammonia. So as soon as you're protein deficient, they can get high ammonia. And taurine's important. They can only conjugate their bile salts with taurine. So as soon as they're a little bit protein deficient, all of those metabolic pathways will shut down. So you need to replenish their protein with something that's highly digestible, maybe going to be going down a tube. So it might have to be liquid or that you can solidify, and with decent levels of protein and fat as well. Probably low carbohydrate. They're going to have really low insulin levels. They're going to be insulin resistant because they've got high glucagon and cortisol. So they're not going to be able to deal with big carbohydrate loads. So you're going to want to give them something low in carbs, and you're going to want to do it slowly to prevent refeeding syndrome. So if they've got hepatic lipidosis, they're going to be anorexic for a few days. If they've not eaten for 3, 4, 5 days, then you might want to reintroduce just a small amount of their RER and then work up. Other nutritional things would be, you're probably going to supplement their B12. I'd probably just supplement it rather than testing it in a hepatic lipidosis cat for cobalamin, because cats will easily get cobalamin deficient after anorexia, which will worsen their gut health and also leads to high ammonia. So another reason to do it. And you might want to proactively supplement their potassium, because as part of your refeeding syndrome, when you get that big potassium shift, you can assume that they're probably whole body depleted.
That was a two-level answer. You've got all the points on my list.
Cool.
That was seriously an amazing answer. To not even be to be doing that in an oral setting, you're ridiculous. Okay. What about actually, I'm just going to say this is not for an exam, but practicality. All of those supplements that Helen mentioned, particularly the taurine and the L-carnitine, which are really important for urea cycle and Krebs cycle mitochondrial function, are in diabetic foods. So it's a really good option for if you do ever have a cat with hepatic lipidosis, if you can blend it up and get it calorie dense enough. It's got really high protein, really low carbohydrate. It's got exactly the profile that kind of works for hepatic lipidosis, as opposed to like AD, which tends to be all the manufactured critical care foods tend to not have quite the right balance. And then you don't have to mess around with too many supplements and stuff like that. It's just already in the food. Okay. Now, I don't know, we could go so deep into nutritional management of gastrointestinal disease, but there's actually a subject coming up on alternate diets, and I think we might meld those two together.
Okay.
So I don't want to talk too much about nutritional management of gastrointestinal disease because I don't think it's very examinable. It's kind of a bit fluffy. Can anyone think of any questions or?
No, I guess they could ask in more of like a long term, that year that had the big 30 mark, approach to chronic small bowel diarrhea.
That's such a bad question.
I guess, like you say, we would fluffily say, working through highly digestible, hypoallergenic. I don't know. I can't really think of any questions that in particular they would ask, but I guess we'd use it as part of a longer question, I'm saying.
Yeah. But then kind of you've hit the nail on the head, really with a lot of the chronic enteropathies, it's this mismatch of dietary antigen and content and microbiome and mucosal barrier. And so anything might shift in that equation and you have to kind of change your approach. So it's kind of trial and error really, isn't it?
I have a question actually. This might be really dumb. When we're doing a novel protein, which we all love now,
Yeah.
So food reactions are type 1 hypersensitivities, right? So you've been exposed to an antigen, your body makes IgE, they sit on your mast cells in your gut, then you get re-exposed to it, they cause mast cell degranulation, allergic reaction. So with a novel protein, that can't happen the first time the patient eats it.
No.
But once they've been on a novel protein for some time, that same thing could occur. So when we're saying to, just from a practical point of view, we say try a novel protein for 6 to 8 weeks to do we have a cutoff of what we should be saying? If it then starts failing, it could be that the body's now developed a hypersensitivity to that novel protein, or do we not really see that happening? Does that make sense?
Yeah, for sure. So most allergies are like a combination of genetics and environmental trigger. So the chances of having a genetic predisposition to an allergy to beef protein, chicken protein, turkey protein, fish protein, venison, roux is like slim to nil. Like there's going to be a protein out there that the environmental factors aren't going to be enough to trigger, because there's no genetic predisposition.
Yeah.
We've got dogs that are really sensitive, and we've got dogs that acquire intolerances to different antigens because we've given them those antigens when their mucosal barrier's breached. So when they've got a damaged mucosa, their immune system's sitting there just like, I'm not supposed to be seeing these antigens. I'm going to mount a response to these antigens.
Yeah.
So they then develop an intolerance or an allergy, but it's not a true type 1, I don't think, in those dogs.
Yeah, that makes sense.
Yeah. So those dogs that are just intolerant of all protein sources are usually the ones with mucosal breach or mucosal barrier abnormalities, and they've just got this ongoing rumbling immunostimulation from antigens. And we need to fix the mucosa, and then they won't be intolerant anymore.
And I guess those ones would fail a novel protein diet, but you might try them on an allergenic or something anyway.
Exactly.
So it doesn't really matter. Yeah. I just thought that I was like, I don't really tell owners, in 2 months they could have a reaction, but I guess you're just trying to pick something that the allergen is so different to what they've been on before. Yeah. That makes sense.
Often, I'm in the luxurious position of most of the time when I'm prescribing dietary management of gastrointestinal disease, I've got biopsies.
Yeah.
So I'm usually saying I can see that the mucosa's inflamed and leaky, like leaky gut thing that humans talk about all the time. I'm going to prescribe some pred to seal that mucosal barrier while we're doing a novel protein or like hydrolyzed diet. And then we're probably going to be more tolerant of other diets down the track. Whereas I think when you don't have that biopsy, it's harder to go, let's just throw some pred at it.
Yeah, no, that makes perfect sense.
But throw some pred at it, usually. Okay. I like pancreatic nutritional questions. So let's talk about, what is the association between diet and chronic pancreatitis in the cat? Or any pancreatitis, I should say, not just chronic.
Protein, and there's another thing. Dogs is more what's it called? I've gone too far already. I'm not good at this.
I'm looking at you, making you uncomfortable.
I know. Opened my mouth and then immediately regretted it. Panic.
No, I think that's right, because cats can get chronic pancreatitis more from the protein in their diet, more from the inappropriate protein that's causing a food responsive chronic enteropathy, which is a trigger for chronic pancreatitis, unless they're less worried about fat in their diet for causing chronic pancreatitis, because they actually need a fair amount of fat in their diet.
Yeah, they don't seem to get, so hypertriglyceridemia, either due to just ingestion of a high fat diet or genetic causes of hypertriglyceridemia or metabolic causes, predisposes to pancreatitis in dogs, but not cats for some reason. But I'm not sure whether we just don't have case numbers because cats don't get hypertriglyceridemic. They're just better at dealing with fats because they're designed to eat them in higher quantities than dogs are. So that like the liver just like I'll just deal with that. So it goes straight into the portal system or straight into the lymphatic system, straight to the liver and gets processed. So they're usually pretty good at dealing with high fat diets. So we don't necessarily have to cut fat in cats that we're suspicious of pancreatitis in. But the protein source and enteropathy that often goes along with that is what we kind of need to address. So whatever strategies, throw some predator you need to use to address that is really important. And then the other thing is food aversion in cats. So it has to be delicious. And changing diets will often invoke a period of anorexia if you do it not very carefully. So just being a bit careful about that. Dietary management of exocrine pancreatic insufficiency.
So whatever you're going to feed, you're going to need to put some pancreatic enzymes on there, because by definition, if they've got EPI, they've got no production of their endogenous digestive enzymes. You want it to be really good quality, highly digestible. You don't have to really restrict fat, but you probably don't want to go, you don't want to give the pancreas any other reason to be upset. So I'd say moderate.
Yeah.
Moderate cautious fat.
Moderate fat.
Yeah. And you must supplement B12 as well, because they've got no intrinsic factor to absorb their cobalamin.
Excellent. And what I don't know. Yeah, I don't think you said what other supplements do you put in EPI dog?
So cobalamin, digestive enzymes, and
that's what I'm after.
Oh, sorry,
yeah. What form? Like, can you just, because there's a few like airy fairy ones that are like pancreatic enzymes, but is there one in particular that you will use clinically?
As in a brand name or a no, should I know that? I'd probably write something like that has amylase and lipase and trypsin and is good quality. I don't know.
So a lot of the powdered enzymes just don't work. There's a brand called Creon that does capsules.
Oh yes, Creon, yeah. Okay.
Creon, yeah. So that's been the only one I've ever had success with, and it's expensive, of course. And owners then go out and source their own, and then they come back in with their dogs lost 5 kilos and pooing mountains of food. And they're like, but I'm giving all the enzymes. I'm like, no, you're not.
Is that protected from the gastric pH or not? No.
Yes, in theory, but what a lot of people actually do, so there's actually a really good just like pet owner site called EPI for Dogs, number 4 dogs. And there's this forum in there where people have just said, this really worked for me and this really didn't work for me. And there's like dogs in there that they can have the capsules on their food and they cope really well with it. There's other dogs that just doesn't work for, because in theory, if it's in the capsule, it'll break down on the way through the stomach and then be active in the duodenum where you want it. But most people actually find that breaking the capsules open, stirring it through the food so that that's already partly kind of being digested before they eat it, they find that works better. So that's not examinable at all. But if you ever got a case, I literally just send clients to that website and just say, this is going to be frustrating. You're going to get more options from here of what to try than you are of coming back into me. And it's going to be a lot cheaper. Yeah, so there's so much info on there. Actually, I Google that every time I've got an EPI dog coming in.
Oh, sorry.
Go ahead.
I was just wondering about fiber and restricting it to increase fat absorption.
Yeah, good. So absolutely. Is that the only reason why we restrict fiber?
No, I think from my understanding it was just for the fat absorption, but I'm sure there's more to it.
So it is sort of for fat absorption, but a high fiber diet is retained in the stomach for longer. So if we just trying to think. If we get food retained in the stomach for longer, then the digestive enzymes that we're giving are more likely to be denatured in that environment before they move through to being absorbed. It
Yeah.
would be my like first principles theory, but
Yeah.
the literature definitely says low fiber, but I haven't got the reason why written in front of me.
Yeah. Okay. That makes sense.
I was going to ask a couple questions.
Yeah.
With obviously the fat soluble vitamins might be affected at the absorption. Have you ever had to supplement any of those? I can't, like, they don't recommend it in any of the readings that I could find, and no one seems to be doing it.
No, it's a really good point, actually.
Do we-
Yeah, I don't know.
do they not seem to get issues with A, D, E, and K?
Yeah, like I've never seen a coagulopathy in an EPI dog, which is weird, right? Like that's actually a really good point. Vitamin A, D, and E are like hard to detect and diagnose, but vitamin K is pretty obvious. They're deficient in that. So yeah, I've never thought of that, but it's a really good point. I just wonder whether they're just absorbing just enough, maybe, that because you won't get a coagulopathy until your coagulation factors are 20% of normal or lower. So maybe they're absorbing just enough vitamin K to keep like in that like above 20% range.
And the other question was, in terms of the pathophys and how you, if you lose the exocrine part of your pancreas function, you also lose that bicarbonate part in your
Good, yeah.
duodenum, and so then you get that bacterial overgrowth or whatever.
Yeah, they've often got quite messed up microbiomes.
Is there nothing nutritionally that we would give for that? It seems like from the readings, people give antibiotics for if they need it, but
Overgrowth, yeah. The literature on SIBO is so controversial. Like it's almost like there's no way I'd write an exam question on this at the moment. Because there's whole schools of thought that are like, you can't give antibiotics. You're going to have that once they have antibiotics, they're going to be on them for the rest of their life. Like you're never going to get them off. You can't replace that bicarb. Like once that's gone, that's gone. And as you said, bicarb is responsible for, so essentially acid comes out of the stomach into the duodenum, and that does a little population control on the bacteria that are acid sensitive. And then immediately after they get that acid flux, you get this flush into the duodenum from the pancreas. So we get this acid base fluctuation, and that manages the bacterial populations in the proximal bowel. So if you've got duodenal like stability of pH, you're going to have more bacteria there, which is going to make you more prone to bacteria ascending pancreatic ducts and bile ducts, which is one of the factors contributing to both cholangitis and pancreatitis, which is what we want to avoid, particularly in cats. So in theory, we want to manage get the bacterial population, but we want to do that by, in my opinion, by competing for binding sites and competing for nutrition. So we can do that with probiotics. We can select for minimally pathogenic bacteria, which are going to compete for binding sites with prebiotics in the food. So adding things to the food that feed the bacteria that we want to populate that area, and feeding really consistent diet to make sure that those bacterial populations stay quite stable, just so we don't get like fluctuation. So if you feed like one thing one day and one thing the next day, like carbohydrate level wise, the bacteria you get in that area will be quite different. But if we're really stable about it, then we can keep that really uniform. And then another one that's interesting, I haven't seen any literature on it, is a yeast probiotic, because it balances out bacterial numbers, competes for nutrients with bacteria, and therefore just not as many bacteria can populate an area. So I'm interested in the theory behind that. I wish Matt Muir was here. He would tell us a lot about that.
Are you talking about the Saccharomyces?
Yes. Yeah. So black moles have got what's
I
it
use
called?
that in koalas every day.
Sorry?
I use that in
Oh,
koalas
you
every
do?
day. Yeah.
Yes. Why?
Candidiasis, to prevent candidiasis. GI
Oh,
candidiasis.
because it competes for binding sites with Candida. Oh, interesting. Yes.
I haven't actually looked at our outcomes, and I need to actually look into it. We were just trialing it for a couple of years, but yeah. What supplements do you use? Would you personally use? I know it's not examination worthy, but
No, yeah, exactly. So what I usually do, I'm a huge fan of a whole food diet. It's just got less filler in it, and you actually kind of know what's in there. And I do. Matt's not on the call, so I'm not like flirting or anything. But Leica is like one of my I recommend it all the time. Just a whole food diet that you know is responsibly manufactured, that you know has a nutritional balance, and you can pick from their range. And there's always one of their diets that's appropriate for whatever illness you're dealing with from a gastrointestinal perspective. They add prebiotics, which are evidence-based, and you can select for those bacterial populations we talked about. And then I would probably add something along the lines of symbiotic, which is my favorite probiotic. Or there's one that is a human one, and it's the split of bacteria is the most studied kind of probiotic split. So I can't remember what the three bacteria in there are, but if you can get a human form of that one, I'd add that one if they don't want to spend on symbiotic. And then if I wasn't getting success with diet first, adding probiotic second, then I'd add in the Saccharomyces probiotic and just see, like, I just kind of try one thing at a time.
What's the last one that you said?
The Saccharomyces probiotic, the yeast-based probiotic, I think
Okay.
it's called something SB.
we get Yomogi
Yamoki.
chemists. That's the brand name that we get.
Oh, right.
Is that
There's
what
one, yeah, Pause Blackmore, like do a dog one. They market a dog one. But yeah, it's probably much cheaper from the pharmacy. Yomogi.
Ah, yeah, SBs, what it says online.
Yeah.
Did you do this would you do this for every EPI patient that you have?
Yeah, which I have to say, it's pretty rare. I don't have that many API patients. I had a cat the other day who was like 4. That's unheard of. But yeah, we don't see very many. This is more chronic enteropathy management because microbiome management is like key to like gastrointestinal, pancreatic, liver, all of them. Yeah. So
Would a 4-year-old cat have EPI from chronic pancreatitis? Or is that an immune-mediated cat thing?
I don't know.
Fun.
Yeah.
I was reading some papers about this and listening to a lecture by Jill Madison.
Oh,
And
yes.
isn't the general thought that we've been underdiagnosing EPI in cats because they often don't have diarrhea, they just have weight loss.
Yeah.
Yeah.
And sometimes vomiting.
And and the TLI obviously only came in a few weeks ago. And that and I think I forgot what the question was. What was your actual question, Helen? What am I answering?
I said, would a 4-year-old cat get EPI from chronic pancreatitis because it's not very old, or would it, because it's sort of young middle age, get it from immune mediated?
And I think that the studies found obviously that there's cats as young as 6 months old getting EPI, and so
Why though? What's the mechanism? Do they know?
well, there's I think everyone used to think it was the pancreatitis was the main issue in cats, but obviously there's still the potential for the same thing as dogs with the
Immune mediated.
or the complete when they don't develop in the first place.
Oh, agenesis or something.
Yeah. What's it called?
That's so
Anyway.
interesting. So another question, which is purely like I've become a philosopher, but if you've got immune-mediated inflammation of the exocrine pancreas, is that not pancreatitis? It's just of a different etiology, right? It's inflammation of the pancreas.
Yeah.
Yeah. So maybe we should put that on our list of causes of pancreatitis. Interesting.
Maybe the cells, because the cells of the exocrine and endocrine pancreas obviously get attacked very differently, because you can have like diabetes without EPI. So maybe they're like the immune system that attacks mine is just so different. Yeah, the antigen's so different.
Yeah. Interesting.
That's a good point, Julian, because I think how often we see cats with weight loss that we don't know, or we give them pred. And I very rarely test TLI, so maybe it's something we should add to the vague weight loss.
I'm going to message Tunbi, who like checks all our reports and adds medical recommendations for our ultrasound reports, and say add TLI to all our weight loss cats.
Yeah,
So
it's good.
I saw 2 yesterday that I should have put that in the list of what to do.
Jill sent us a good reading that I can send to Anna to send.
Oh, that'd be great.
Thank you. Yeah, you're not to read that before exam, Helen.
Okay. Just staying on the biome topic a little bit, do you think something I don't feel I know that much about, because I've never used, because I don't really know what to do with it, but I know that we see vets that do use it, is like a dysbiosis index. Do you think that's too controversial to examine us about? Okay.
Yeah, it's not used often enough in Australia. So dysbiosis index is run in Texas, I want to say, somewhere in America, which means you've got to ship poo to America, which means you've got to get Homeland Security clearance and stuff like that. Like, it's a lot of paperwork, it's a little bit of a pain in the ass. The poo's often died by the time it gets there. You've got to keep it at a really stable temperature, I believe, as well. But because it is a genome test, it's probably quite stable. But yeah, I'm really interested in that as we get more data, and I feel like we won't get more data unless we start submitting them.
That's true.
Yeah. Again, we might delve into that when we do them alternate diets, and I might see if we can map to attend that one so we can really do a deep dive. Because yeah, he can answer all of these questions. Maybe we should make a note of them. Okay. While we're on pancreas, but different type of pancreas. Oh no, I don't want to do that. Sorry. Tell me what the pathophysiology of feline hypothyroidism is.
So cats with hypothyroidism get an adenomatous hyperplasia of their thyroid gland. So they get upregulation of their thyroid hormone productions. It leads to a myriad of consequences. So the thyroid hormone upregulates your metabolism. So you enter a catabolic state because they can't keep up with their metabolic demands. It's also has positive chronotropic and ionotropic effects. So it stimulates increased tachycardia and increased contractility of the heart, which adds to the workload of your ventricles. So you get left ventricular hypertrophy and a hypertrophic cardiomyopathy phenotype. It increases vascular tone, and so you get increased systemic vascular resistance, so you get hypertension. And this isn't a very coherent answer. The pathophys, so we should talk about what it's actually doing. It has so many effects. It impacts your gut health and your mucosal health, so you get gastrointestinal signs. I'm not entirely sure how thyroid hormone does that. I don't know if it's through upregulation of your metabolism or...
Actually, increases motility.
Oh, yes. Oh, yeah, weird. Increases motility.
Transit time, which means like food absorption is decreased, digestion is decreased, and then it disrupts the microbiome because like the antigens moving through are different.
Yeah. In very rare cases, about 5% can be a carcinoma, which are really hard to control. That's not really pathophys. Probably won't need that in that answer.
Cool, you've got everything on my
list. Okay.
Yeah. And yeah, you're never going to be asked in an oral exam setting. You're never going to be asked pathophysiology. Welcome, Mitch.
Sorry, I was making a coffee and I've just been lurking in the background. About hormone and activating of renin and RAS. Would you mention that in a pathophys question as well?
Yeah, that's a really good question. A really good point, actually, because not only do they have increased vascular tone, but they've got fluid retention. So they've got 2 causes of hypertension. I probably wouldn't expect that at a membership level for the question that I asked, like talk about the pathophysiology. And like in that situation, if you look at the question and say describe the pathophysiology of hypothyroidism, and it's a 3 marker, you're going to say like exactly what you said: adenomatous hyperplasia in 95% of cases, 5% carcinomatous, causing increase in T4, T3, increasing basal metabolic rate, resulting in gastrointestinal signs, cardiac signs, blah, 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 full stop. And then if it was a 12 marker, then you're going to go into a little bit more detail and RAS and stuff like that. But yeah, do look at, because yeah, if you try and just put down everything you know about every question and it's only worth 3 or 4 marks, you won't get through the paper and you'll lose marks. Are you sitting too, Mitch?
Yeah.
Oh,
Yeah.
How are you feeling, Mitch?
Good. I was good up until yesterday, and then I hit the wall. I've had about a week and a half off work, so I'm just ready to get it done now.
I think I was in the wall at this point where you guys are.
Yeah, no, I'm feeling good. It's just getting it over and done with now, I think is going to be the fun part. So yeah.
You guys say it's on Tuesday?
Yeah.
I was saying to Helen, this is not the week. Like if you were preparing for a marathon, that you wouldn't be running 40 Ks every day this week. Like this is the week to just be nice to yourself. And whenever a question pops into your head, you go, oh, I'm going to look at the answer to that, because that's the sort of thing you're going to retain. Whereas if you're just trying to read through notes, you're going to go insane and you're going to drive yourself nuts because you're not going to retain anything. It's too stressful. Okay, I've got another question. You ready? Describe the pathogenesis of coagulopathies in liver failure.
You are jumping around today, aren't you? Okay. Liver failure. So the liver makes your clotting factors are proteins, which your liver is responsible for your protein synthesis. So your liver makes them. So you need severe liver failure because, like you touched on earlier, you can remain normal hemostasis with until you lose 80% of your clotting factors. So you're going to have lost a lot of your hepatocytes. It's going to particularly affect secondary coagulation. So you're going to see large volume bleeds without your clotting factors. So like pleural effusions, hemoabdomens, bruising into muscles, bleeding into joint spaces, CNS spaces. So the clinical signs could be quite variable, either directed to where you've had a bleed or to hypovolemia secondary to hemorrhage. What else would we need for that question?
Which factors are the most vulnerable or the ones that tend to get low earliest?
I want to say 7 for 2, 7, 9, and 10.
Excellent. Yeah. So there's 2 kind of mechanisms for the clotting factor deficiency. One is decreased production by dysfunctional hepatocytes.
Oh, and the other one is if you've got cholestasis. Sorry, I didn't mean to interrupt you. Yeah, because you're not going to be reabsorbing them with severe cholestatic disease.
Yes, exactly right. Yeah. So vitamin K is heavily dependent on being recycled through intrahepatic recirculation. And so if we've got cholestasis, then we don't get vitamin K recirculated into the intestines to facilitate absorption of the clotting factors or the protein. But you end up vitamin K deficient. That's what happens. Sorry.
Yep.
And then the other thing is the fibrinolytic products are actually cleared by the liver as well, so they're retained for longer. And that's very, like, I've never heard that before, but I find it very interesting. So it's not something that I'd expect at either a membership or a fellowship level. But we can't measure fibrinolytic products in dogs and cats, so it's not something that we've got evidence for. Well, not well anyway. Okay, what about the
Was that
mechanism?
based on humans, Anna, then?
Yes.
The
Yeah.
evidence?
So they can measure fibrin degradation products and D-dimers really well in humans. So they can measure like fibrinolysis better, where we're not very good at it. As we get more like thromboelastography and stuff, we're going to be able to detect like changes in clot formation and changes in clot breakdown better, but it's just not done often enough.
Hannah, do you think they would examine us on TEGs and things, or would that be more critical care?
Critical care and also probably fellowship level.
Okay.
Yeah, no way. That would be so mean.
Good, because I haven't done that.
You know any clinics that have got one?
No. I just listened to a webinar the other day and I was like, this is interesting. But then it kind of went out my head because I was like, maybe they wouldn't ask us about this.
Yeah, not relevant.
Cheryl, you were nodding. Do you have it?
I think we have it in SASH, but it's usually like critical care and ECC.
Okay.
Yeah. SASH North Ride?
Yeah.
Interesting. So I did 7 years of a PhD that I never finished on clotting in dogs. And we did a lot of TEG as part of that study. So we had blood from dogs with all sorts of pathologies, and we did like we developed a new assay that looked at fibrinolysis. We compared that with TEG. They've got another machine called a Rotum, and we like similar to TEG, and we kind of compared them, all the results and stuff. Really interesting results that I never published. So if anyone wants a research paper, I've got one you can write up. And the lab that I worked with would be really thrilled if someone wrote it up.
Someone did something with it. Were you more looking for what makes patients hypercoagulable? So knowing which patients are at risk of clots? Or?
Yeah. So I find it really interesting that we can measure hypocoagulability, but we can't measure hypercoagulability. And some of the dogs that on our APTT PT measure high and theoretically should be predisposed to bleeding are the ones that have got clots. And I find that like it's such an interesting kind of balance of things. It's like microbiome. Like it's like so many moving parts that could be contributing or out of balance to, but then it changes minute to minute. So you've got to have all the tests on the spot. And then I'm not a criticalist. That's the criticalist. Okay. Tell me the mechanism of action of imipitoin.
Is anyone screaming to do this? It's a licensed first-line anti-epileptic drug. And I can probably tell you what another first-line anti-epileptic drug does.
Is it similar to Pheno? Sorry, Helen, you've answered all the questions, so I feel.
Do you know what? I don't know. Can we answer it on Pheno? No, go for it, Mitch.
It's similar. Well, it's similar in theory to Pheno in that it's is it like promote inhibitory effects on GABA? Well, that would be
Pheno like accentuates the inhibitory action of GABA. Yeah, so it binds the GABA receptors and increases the affinity of GABA binding and makes the GABA channels open for longer.
Yeah,
does it do that too?
It's exactly the same mechanism.
Yeah, I thought its mechanism of action was similar.
Yeah,
Great.
it just reduced hepatotoxicity. So, hepatotoxicity or hepatic side effects compared with phenobarbital. So that's in theory like slightly different like way that it works, different part of the receptor, I think. But it is, the reason I asked that is because it's actually really almost like a double negative. So it enhances the inhibitory effects of GABA. So it's really important that you get that sentence structure right, because it's really like it's a bit of a brain, you know what I mean?
Yeah.
So enhances inhibitory effects of GABA. So GABA is the neurotransmitter in the brain that slows things down. And when we think of that, and really first principle is what triggers an action potential. And remember, we've got that cell membrane, and then we get this little influx of positive ions into the cell, and then the basal like resting charge inside the cell goes up because it's becoming more positive inside. Then we get to a threshold and all the sodium channels open and all the sodium rushes in, and that gives us an action potential. So if you've got enhanced inhibition, you've got something that makes it harder to trigger an action potential. So you've got that cell membrane actually sitting, the inside of the cell sitting at a more negative level than it would be at rest normally. So GABA, anything that enhances GABA, so phenobarbital and mepitonin, causes influx of chloride ions into the cell to make it more negative, make it harder to trigger an action potential in that cell, and therefore harder to get that seizure activity developing. Does that make sense?
Perfect.
The other thing that imepitoin does that's slightly different is that it actually blocks some of the sodium channels as well. So not only does it increase the chloride influx, but it means that if you do get to that membrane potential, that trigger potential, what's that called? Resting and then threshold? Yeah. If you do get to that level, those voltage gated sodium channels just aren't going to open. Not all of them are going to open. So it won't be as dramatic a...
Less permeable to sodium. That makes sense.
Good. Okay. New question. Last question. Oh, it's 9 o'clock. We're done. Sorry, everyone. I've got to take my kids to school.
Thanks.
Good luck next week, everyone. If you've got any last minute questions, I can answer them over email over the weekend. I will be around and writing talks and looking for any excuse not to write talks. So let me know. And I'll see you. We're going to do similar kind of structure for the next two. Basically, like we'll kind of do questions based around the subject we're supposed to be covering, but we'll really jump around just to challenge you.
Okay. Good luck, everyone.
Good
So
luck,
just-
guys.
Thanks so much, Anna.
A link to that paper.
Oh yeah, link in the chat for that paper that I was talked about.
Just before I close the meeting. All right.
Bye.
Hey guys.
Thanks, Anna.
Bye.
Bye.